People, 9 a.m. is not usual. Thank you for the recording. This meeting is not usual at 9. It's usually our meeting is at 10, but thank you for make that extra effort. And I we expect big things on this QIP webinar. So with that little short welcome, I'll pass the ball to Miranda. Good morning.
Good morning, everyone. Thank you all for being here. Very excited. This has been a much anticipated, lots of work, time, and energy has come to pulling together our first official QIP as EHE and Ryan White. Very excited. Thank you.
So Regina.
All right. Good morning, everyone. So if you could please enter your name and your organization in the chat room for us, please. Let us know where you're from, who you're representing here today. And just a few Zoom housekeeping. You can hit escape to exit your full screen mode. You can hover over at the top right hand side to adjust your view options. So if you want to see gallery view, or if you want to see just the person speaking, you can do that. And place yourself on mute. We please ask that you do that until you're ready to chime in. We highly encourage the use of your webcams if that's possible. Thank you for those who've already joined us with your smiling faces. And use the chat room if you want to interact with us, if you have any questions for your colleagues or for the team. And this meeting is being recorded, so it's available to share along with your toolkit after the meeting. And I will turn it over to Angie. Thank you.
Thanks, Regina. Good morning, everybody. Just going to go over some of our goals for today for the webinar. So we're going to explore the available data on a linkage to care and our project and the relationship of the STIs. We're going to describe the expectations for this year related to linkage to care at your provider level and also at the AA level. Also reviewing the model for improvement, discussing how linkage to care can reinforce our rapid start here in Dallas, and identifying next steps for the next webinar that happens in June. Next slide, please. And then these documents are going to be available in the toolkit on Glass Cube. So we have a presentation slide from today, which is very juicy and full of good, meaningful details. We have a PDSA document, which is a Word document, an AIM statement template, which is also a Word document, a root cause analysis form, which is a Word document, and some rapid start literature. So I will kick it over to Jamie, I believe now. Thank you.
Awesome. Thank you, Angie. So we want to wake you up and get our brains moving and grooving. We're very excited to have so many different colleagues here on the call. So we're getting ready to do a little game time. Are you feeling lucky? Let me talk through what's about to happen. So the purpose of this game is we want to develop relationships, right? We've got colleagues from Dishes, we have Dallas AA staff, community members, and our funded network. So let's develop some relationships. Wow, we have a little quiz game fun in terms of our knowledge around HIV and STIs. So what's about to happen is there's going to be randomized breakout groups. There's going to be 5 breakout teams. There's already a designated facilitator and a designated note taker who are going to join that session. Your facilitator is going to share with you a set of 10 quiz questions. And we have 10 minutes in this to kind of rapid response to those questions. So it might be a true or false question or something like that. Again, everything connecting back to HIV and or STIs. After 10 minutes, you will be automatically teleported back into this main Zoom room when the breakout closes. Your note taker, if you are a note taker, you want to check the responses. I'll share the correct answers. So let's see out of our 5 breakouts, who can get the most correct answers. Let's say you get in a breakout room and your team is like, I don't know, can we skip number 2? Yes, you can. You can always skip a question and come back to it. Does anybody have questions as we are getting ready to go into some breakout rooms? All right, if it makes sense, it makes sense. I want to say welcome. I want to say welcome, Dr. Nguyen. It's great to have you. Let me launch some breakout groups. You're going to assign random breakout groups and create them. So folks should see an open Zoom room. And if you are Dallas County staff, let me make sure we got everybody in the right place. Go ahead and join that Zoom room and we'll get started. Good luck, quiz teams. AOP. Octavio, you are 4. OP, I can't. OP, can you move yourself? Hi, Juliet. Oh, I'll move you. You're 4, OP. You should be good to go now. Hi, Nisa. All right, everybody, welcome back. Welcome back. I don't know how you're feeling. Sanjita said it almost raised more questions than answers. So I don't necessarily know how all the groups are feeling, but good to have you back. I hope you enjoyed some of that. Let's look at the scoreboard. Let's look at some of these answers. So if you're a note taker, check what your team came up with. Maybe you got through all 10, maybe not. But are some STDs or STIs associated with HIV? That's a yes. If someone living with HIV maintains an undetectable viral load and they test positive for an STD, does that STD increase the risk of transmitting? The answer is false. And the most common STI symptom, it's no symptom. This is also why screening is so important. For our trivia fans and historians, when was syphilis first recognized as an epidemic? Baby, we're going all the way back to the 1400s. And then, dang. And then in terms of what year was the first HIV test approved by the FDA? 1985. Fabulous year, might I add. Which group is most likely to have an STI? We're looking for our teens and young adults. Is it true or false that sex toys can spread STIs? That is true. And then which is the most common STI caused by bacteria? That's chlamydia. Question 9, gonorrhea is treated with antibiotics. But what problem has occurred recently in treatment? You had a handful of different challenges to choose from. We're looking at the bacteria that causes gonorrhea has become resistant to certain antibiotics. And then finally, question 10, which major organ can be affected by untreated syphilis? That was actually A and B, which would be your heart and your brain. How did folks do? Drop in the chat or let us know. How did that feel?
Our group did really well. We got 7.
Okay.
Well, group 2 have 8, correct?
Okay.
You know what? Group 5, we would have had a 100, but we needed like 10 more seconds to answer the last one.
So did you get 8 or 9?
We got all 9.
Oh,
My group got 7 as well.
okay. Much love, much love. Okay, we got some old geniuses. Y'all, and Michael dropped in the chat, there ain't no asterisk in that U equals U all. So fabulous. That's also, I think, another layer of why U equals U. Patient education and empowerment is so important, right? There is no asterisk, baby. All right, we are getting ready to keep moving and grooving and rolling. Give me 1 second to queue up our slides. Sorry, folks. Thank you. I hope y'all had some fun and you met some new colleagues as well. Give me 2 seconds to get my meeting controls in order. And I'm going to kick it over to Oscar.
Thank you, Jamie. This is interesting, and I want to say why we decided to have this linkage to care project, how we decided that, how we come up with this. Okay, in 2023, we started working this idea because in 22 we worked on those who are linkage to care, I mean retention in care. But in 2023 we decide, okay, what's the main situation that is very frequent and happen as a constant, basically, that 25% of the people who are diagnosed are missing in action, lack of linkage to care. We decided to dig deeper into that. And here it is happening that EHE has one of the pillars integrated into the equation. So we have linkage to care with the testing side, integrating one big program and big impact program by 2030. And what happened then? The state decided to come up with the project linkage to care within 30 days. So, okay, here it is, big events, big personalities, big department, big action are lining up. And ATC, one of the big educators, is having some extra component in educating people on Rapid Start. And different institutions are focusing on Rapid Start. Some hospitals, some local clinic are already starting the initiative, already working on the initiative of Rapid Start, link people into care as soon as possible. And then, despite of this difficulty, the part of the lack of the structure, we decide to come up and say we should address this issue and narrow down to have linkage to care in 7 days. Even though the stage is 30 days, EHE will be more aligned with us into that. So see, the picture is big. We are aligning the planets with events that happen and change everything in this epidemic. So this is a huge data collection over time. We'll have almost 2 years of data collection by the end of 24, and we'll be able to present some conclusive data and where are the gaps, work on the gaps, and bring people into care and work toward the end of the HIV epidemic. Thank you very much for coming and be part of this event. This is going to be big. This is going to be very remarkable in public health. Social determinants of health will be addressed, and we'll talk about that. Thinking about Piper, we hear you. We bring some national data to you. Thank you. Go back to Jamie.
Thank you, Oscar. Thank you. Thank you. So just as a reminder, right, this is also part of our effort to integrate. We have clinical quality management, which also has love for our non-clinical sites. Don't let that term fool you. But we want to implement a joint effort with our quality improvement project. So quality management is our umbrella, and our EHE programs and our Ryan White programs are coming together under that. So we want this quality improvement or QI project to reside and be coordinated across both our Ryan White HIV/AIDS programs and EHE funding streams. I think Miranda is up next.
Thank you, Jamie. Yeah, we have the most amazing agencies here, and this is all part of our efforts to have a really coordinated system to set these common goals and common strategies to achieve these goals so we can really be intentional about moving the needle quickly. We don't have all day. Speaking of ending the HIV epidemic, hopefully we all know by now, but it's a 10-year initiative, 2020 through 2030, focused on reducing new HIV transmissions by 90% in 2030. Hence, what can we do that's very intentional so that we can make things happen quickly and not continue on the same cycles. We can go to the next slide. Thank you. So, on the Ryan White side, we have specific category service standards, and they're very clear cut. With EHE, it's intentionally more flexible. And so we have what we call 4 pillars, and that's diagnose, which is really focused on testing, treatment, which is care, access to care, prevention, PrEP, SSPs, and then respond. And that's looking more holistically, the human being, anything that can be a barrier, and also looking at rapid transmission opportunities for us to better synergize. Thanks, Jamie. I think that's it for me.
Yeah, thanks, Miranda.
Yeah.
Michael.
Now, you heard us talk about this a lot, especially me, the naked emperor, right? We don't want to be the naked emperor. We don't want to be fooled or swindled by misconceptions. And the greatest misconception that we can have actually are the assumptions we make, and how our passion can blind us and take us down a route that is not productive or necessary. So, we are supported by PCN 1502, that our QIP and all the activities we do, frankly, should be data-driven. It is 2024. We have big data available to us through our systems. It's basically impossible to compete and stay alive as an organization these days without big data. So why not use it? Why not use it? So we're going to start with our nesting dolls approach at the biggest level. And it's my pleasure to introduce my friend and colleague, Dr. Bryce Furness, who's going to walk us through some of the slides that he's put together from the CDC related to this topic. So I'd like to turn it over to Dr. Furness. Welcome.
Thank you, Michael. Good morning, everybody. So I'm excited to be here. Jamie, will you pull up my slides when I say that? Yeah, if you don't mind, and then I'll just tell you in advance. I need to say that I work for the Center for Disease Control and Prevention, and I work for the Department of Health in Washington, D.C., but today I'm presenting my views. I'm not presenting anything from them. So this is using CDC data, but it's basically, my disclaimer is that I'm not talking for CDC or the DC Department of Health. I'm going to talk about the syndemics of STIs and HIV, and hopefully you all know that HIV, substance use, viral hepatitis all affect similar populations and STIs, and each of these health concerns affects the others. That was one of the questions in the quiz, that HIV and STIs are associated, so you've already been introduced to this. What's needed is a holistic, whole-of-society approach, including addressing social and economic barriers, and that's definitely required to improve this endemic. I get very frustrated working in a publicly funded STI clinic when we can only focus on diagnosing and treating infections. We can't really deal with housing instability. We can't really deal with food insecurity, all these other things that are affecting the health of these patients that we're continuously and over diagnosing and treating sexually transmitted infections in. STIs like chlamydia, gonorrhea, and syphilis increase the chance of getting HIV, and STIs also increase the chance of transmitting HIV to others. It's important to know this because an STI does not need to cause symptoms. You don't need to know you have it in order for it to increase your risk of either acquiring it or transmitting it. Some CDC data from 2018, 6% of sexually acquired HIV infections are attributed to gonorrhea, chlamydia, or syphilis. And extrapolating that, in 2008 also, the lifetime medical costs of the 1,896 new HIV infections from 2018 were attributed to gonorrhea, chlamydia, and syphilis totaled $800 million. So when we think about this, the numbers are high, the costs are high. Next slide, please. All of the slides I'm going to present are available on CDC's website to download if you want to use them. This is chlamydia, the reported rates of cases by year in the United States from '84 to 2022, which is the last time we have national surveillance data available. You can see that it's been gradually going up with a little blip during COVID, where we saw some decrease. The reason we saw decreasing is because chlamydia is the silent infection, and in order to find it, we have to screen people, not diagnose them. We screen asymptomatic individuals, we diagnose symptomatic individuals. So we weren't screening as much during COVID because we were all in lockdown. So you can tell that the more we look for it, the more we see it. Historically, this has been the funding source for this used to be through the Infertility Prevention Project, or the IPP. Those of you that are dinosaurs like me on this call will remember the Infertility Prevention Program. We expanded from screening women of childbearing age to males and females up to 45. Then we started screening extragenital sites of gay men. So the more we look for it, the more we find it. So we've had a gradual increase from 1984 all the way up to 2022. Next slide, please. Chlamydia basically affects females more than males, and it's a disease. This was another question that was in the quiz. It predominantly affects young adults and adolescents, so 20 to 24 and 15 to 19. You can see the female ratio among 20 to 24-year-olds is 3,532.3 cases per 100,000. And it's for males, same age category, 20 to 24, it's 1,571.2 per 100,000 population. And then the most impacted group for females is 15 to 19 years of age. The most impacted group for males is 25 to 29 years of age, but followed closely by those 15 to 19 years of age. Next slide, please. I love this graph. It's new. CDC just started including it this year in their public-facing presentations, but I like it because on the left, it shows which group, how much the population is made up by that group, and on the right, it's how much of reported cases are made up by the group. So for example, we're going to pick Black or African American, which is the dark blue, and you can see that they make up 12.6% of the population in the United States, but they make up 28.4% of African Americans in the country. So it's third down on the left, but it's number one on the right. That's just highlighting that there's huge disparities among sexually transmitted infections. Chlamydia is one of them. This is even worse in Washington, D.C. The percent of African Americans in Washington, D.C. is about 55%, but they make up greater than 90% of the cases here in Washington, D.C. So those disparities are great across the country, but they vary depending on location. Next slide, please. I'm showing this just so you can see the changes in the last 10 years. The map on the left shows Texas, and on the map on the left, I believe Texas is 377 to 450 cases per 100,000. And then in 2022, again, the last year that national data is available, they're much darker blue, and it's 499 to 569 cases per 100,000 population. So the cases are increasing all over the country. The cases are increasing in Texas, and these maps show you. If you go to the website, there's actually a nice graphic that goes through 2013, 2014, 2015, and you can see the way the colors shift and the country becomes darker in certain areas. Next slide, please. So this is chlamydia. This comes from the Sunset study, which is the STD surveillance network. It's like a prevalence surveillance system among select STI clinics around the country. And this is showing the proportion of STD clinic patients testing positive by age group, by sex, and by sex of sex partners. So I showed you those graphs before, and we know that most of the chlamydia infections impact those that are 20 to 24 years of age, followed by less than 20 years of age and 25 to 29 years of age. This breaks it down by men who have sex with men, which is burgundy, men who have sex with women only, which is blue, and then women, which is black or dark gray. And you can see that for those that are less than 19 years of age and those that are 20 to 24 years of age, men who have sex with women only are the highest percentage of cases. And then when you get to 25 to 29 years of age, things shift a little bit, and you start seeing men who have sex with men being the highest percentage of cases. Remember this because it's different for the other two STIs we're going to talk about. Next slide, please. So this is gonorrhea, the second bacterial STI we're going to talk about today. You can see the rates of reported cases by year from 1941 to 2020. The reason we see a big increase from let's say the late 1950s to the mid 70s is the sexual revolution, the summer of love. The reality, and one of the biggest impacts of that was that birth control became available. And so suddenly females could have sex for non-procreation purposes. So they could actually enjoy sex, and pleasure became a big thing. You had the summer of love, you had all that kind of stuff. And then you see it peak. It's in the late 70s, early 80s, and then we saw a big decrease. This decrease is attributed to a lot of the same things we saw around HIV. The safe sex messages, the fear of sex, all those different things, condoms, both chlamydia, gonorrhea, and HIV are all transmitted through body fluids. So condoms are very good at preventing the transmission. So a lot of the things that people were doing to prevent HIV in the 80s and 90s also impacted gonorrhea transmission. So we saw that big decrease. And then starting in the mid 90s, we started seeing gradual increases. A lot of this has to do with a lot of different things. We are screening extragenital sites. We are screening more people. We also have things, another quiz question, antibiotic resistance is a problem. Hasn't really impacted US right now, but it's a problem. We have documented antibiotic resistance among gonorrhea cases to every antibiotic we currently use to treat them in Asia. So, and it will eventually make its way here. So antibiotic resistance, as was pointed out in the questions in the quiz, is a huge emerging public health concern for gonorrhea. Next slide, please. So this is, you've seen this before, these are the rates of reported cases, age group and by sex. And you can see again that for both males and females, the age category with the highest rates are females at 715.1 cases per 100,000 and males at 739.4 per 100,000. So you can see gonorrhea, unlike chlamydia, is more evenly dispersed among males and females. For females, the next most impacted group are 15 to 19 years of age. And for males, similar as with gonorrhea, the next biggest group is those 25 to 29 years of age. All this taken, both chlamydia and gonorrhea, and it was one of the answers to the quiz that we took, is that the most impacted populations of gonorrhea and chlamydia are young adults, 20 to 24 years of age, adolescents, 15 to 19 years of age, and then the older adults, 25 to 29 years of age. This is an infection and a disease of young folks, sexually active young folks. Next slide, please. Again, I love this graph. And again, it shows African Americans or Blacks on the left. They make up 12.6% of the population. But when you look on the right, they make up 38% of the reported cases. So huge disparities in both chlamydia and gonorrhea around the country. And then in certain places, it's much more. Gonorrhea is much like chlamydia in Washington, D.C., unfortunately, where the population is 50 to 55%, but the percent of cases with race data is over 90%. So huge disparities. Next slide, please. Again, this map shows you that the differences in the rates from 2013 to 2022, we can see that Texas in 2013 looks like it was 118 to 156 cases per 100,000 population. And in 2022, it moved up to 157 to 210 cases per 100,000 population. But you can see in general, just looking at the map in general, that it's gotten more dark in more places in those last 10 years. So just like chlamydia, gonorrhea is a huge public health problem that is just worsening. Next slide, please. And again, this is the slide we showed you from the Sun, the STD surveillance network. It's showing you the proportion of STD clinic patients testing positive, and it's by age, group, sex, and sex of partners. But you'll notice this is much different because regardless of age group, less than 19 to greater than 40, the folks that are being diagnosed the most with gonorrhea are men who have sex with men in the burgundy line, followed closely by men who have sex with women only, the blue line, and then women, the dark gray or black line. But it's impressive because if you remember this bar graph, this histogram from chlamydia, this varied. Who made up the greatest proportion of cases varied by age group, and that's not the case with gonorrhea. Regardless of age group, men who have sex with men are being diagnosed with this more than men who have sex with women only or women. And I say that because when we really talk about the syndemic of STIs and HIV, that is the population where it's most we see it most is among men who have sex with men. Next slide, please. So finally, we're going to talk about syphilis. These are the rates of reported cases by year, United States from 1941 to 2020. We saw a precipitous drop in the syphilis cases in the late 40s because penicillin became available right around the end of World War II. So we're talking 1944, 1945, and we saw a great decrease. We continued seeing a great increase until the little bump in the 1990s that was associated with the crack epidemic. We then saw decreases again. In 1998, 1999, Dr. David Satcher, who was a Surgeon General at the time and one of my public health heroes, announced that we were going to eliminate syphilis in the United States of America. And he said that because in the late 90s, we had the lowest rates ever recorded since we started recording it in the 1940s. And most of those cases were in rural areas in the South among lower socioeconomic status individuals that were Black or African American. So David Satcher thought that if we just concentrated all our resources on those places, we could eliminate syphilis in the United States of America. Unfortunately, the year and a half, 2 years after we started the National Syphilis Elimination Rapid Response Team, we started seeing increases, and it wasn't among Southern Blacks, it was among gay men in urban areas. And so that's continued. You see that this is a continuing slope. I'm not talking about it today because it doesn't really fit in the syndemic mold, but congenital syphilis, as the cases have gone up among men who have sex with men, it's bled over into the heterosexual population. There are certain cities like Detroit and Baltimore who have parallel outbreaks among gay men and among heterosexuals. But the more women of childbearing age that have been diagnosed and treated for syphilis, the more we're seeing babies that are impacted by it. So even though I'm not spending a lot of time of it, congenital syphilis is a huge public health problem. Next slide, please. This shows you basically the primary and secondary syphilis rates. That's the infectious stages of syphilis reported by age group and sex. This is almost the mirror image of chlamydia. Chlamydia primarily impacted females more so than males. This impacts males more than females. And you can see that it's quite different. The age group that's most affected is 30 to 34 years of age for men, with 70.5 cases per 100,000 population. And then it's a tie between 25 to 29 and 30 to 34 for females at 24.1 cases per 100,000 population. So this is not a disease of heterosexual youth. This is a disease of men who have sex with men and older men who have sex with men and the women that they have sex with. Next slide, please. Again, I love this. So it shows you the disparities, not as much as with chlamydia and gonorrhea, but still African Americans and Blacks on the left in blue at 12.6% of the population. And on the right, they're second from the top at 31.7% of the population. I will point out, although it's hard to see because the First Nations are being really impacted by syphilis and congenital syphilis, but you'll see that American Indians and Alaska Natives on the left in black are 0.7% of the population, but they make up on the right 2.8% of the reported cases in the United States of America. So we talk about the disparities based on race and ethnicity. There are huge disparities with syphilis among Blacks and African Americans, but also, and maybe even more so, among American Indians and Alaska Natives. Next slide, please. Again, this shows you the graph for the United States of America comparing 2013 to 2022. And you'll see that Texas went from 3.6 to 5.9 cases per 100,000 in 2013 to 13.6 to 84.3 per 100,000 population. So really, this has been the biggest change for Texas in this 10-year period. We saw a pretty big change for chlamydia, less of a change for gonorrhea, but a significant change for syphilis cases in Texas in the last 10 years. Next slide, please. Okay, this is a little bit different because it gets more to the syndemic lens that we're looking through, but this is primary and secondary syphilis, reported cases by sex, sex of sex partners, and HIV status in the United States. This is the year 2022. Again, the last year this data was available at the national level. You can see that men who have sex with men, HIV negatives are in the peach, HIV positives are in the dark orange, and then unknown HIV status is in the light orange. And MSM have the highest number of cases of primary and secondary syphilis among those living with HIV. So I mentioned it before, but when we talk about the syndemics between STIs and HIV, it impacts the entire population, but there are certain subpopulations that are more impacted than others, and gay, bisexual, and other men who have sex with men are heavily impacted. Men who have sex with women only, few of them are HIV positive. Women, even less. And then you have men who have sex with unknown sex partners, which means we don't know who they have sex with. That's higher. That's the next highest compared to men who have sex with men. So this just gives you an idea of syphilis and HIV and the syndemic in the United States of America. Next slide, please. This is another one. It's showing proportion of men who have sex with men with primary and secondary syphilis, and it shows you all three STIs. So again, this is the syndemic lens, and it's looking specifically among men who have sex with men who come into the STD surveillance network STI clinics, and the percentage of those that are HIV positive in the dark orange versus HIV negative. And you can see that for primary and secondary syphilis and gonorrhea, the higher percentage of cases were living with HIV versus chlamydia, where it's pretty close, but it seems like the chlamydia is a little less for those that are living with HIV versus those that are known to be HIV negative. So these last two graphs really give you an idea of the syndemic that we really want people to be thinking about. Next slide, please. And I'm almost done. I think I have 2 slides left. So the take-home points, what I really would like you to take home today is the first thing is that the diagnosis and treatment of STIs is HIV prevention. This is not talked about enough, and unfortunately, it was not highlighted enough in the Ending the HIV Epidemic plan, as far as I'm concerned. But we do know that the diagnosis and treatment of STIs is HIV prevention. If STIs can increase the risk of acquiring HIV if you have it, or transmitting it to others if you have it, how could it not be basically diagnosing those and treating those? How can they not be associated with HIV prevention? So most people affected by STIs include adolescents and young adults. Hopefully I've showed that to you. It was one of the answers to the quiz. Gay, bisexual, and other men who have sex with men. Again, a group that really sees the syndemics between STDs and HIV pregnant people, and some people from racial and ethnic minority groups. And I showed African Americans and Blacks and their disparities, and I showed you American Indians and Alaska Natives and their disparities. I just want to highlight that CDC recommends sexually active, gay, bisexual, and other men who have sex with men be screened for chlamydia, gonorrhea, and syphilis at least annually. And they talk about chlamydia and gonorrhea screening. They should include all exposed anatomical sites. So the urethra, the rectum, and the pharynx. And I'm going to be very clear and very blunt about it. If you're not asking comprehensive sexual histories, if you're not asking if they've had a penis in their mouth or a penis in their butt, or if they've inserted their penis into somebody else's mouth, vagina, or rectum, you are not screening gay men by CDC guidance. It's that clear. If you're not doing comprehensive sexual histories and you're not asking those questions, you are not screening appropriately. And then the CDC is also very clear that they should be screened every 3 to 6 months if it increased risk. And increased risk is a little bit nebulous, but increased risk could be classified by number of sex partners, number of anonymous sex partners, number of pseudo-anonymous sex partners, whether or not the person has sex while high or drunk, whether or not the person engages in sex events, or whether that person goes to sex venues for sex. Ask these questions in a non-shaming way, but you're not going to know whether to screen them only annually or every 3 to 6 months if you aren't talking to them and asking these questions. Because those are some of the reasons why you would screen more frequently than every year. Okay, I'm going to step down off my pedestal and come to the last slide. Next slide, please. So I just want you to think outside the box. And so I'm just presenting 5 different possible actions to improve the syndemic of STIs and HIV, especially among gay, bisexual, and other men who have sex with men. So are you screening men who have sex with men according to CDC guidance? Are you doing that including extragenital sites? Are you doing that frequently, every 3 months, every 6 months, rather than annually based on their risk-taking behaviors? Are you linking HIV negative partners of patients living with HIV to PrEP? This is thinking way outside the box, but when you're thinking about population health, it's important if you're taking care of a person who's living with HIV and you're not talking to them about their partner, you're doing a disservice to that patient and that partner, because we could easily help link those HIV negative discordant relationship partners to PrEP. For those patients living with HIV who are diagnosed with a bacterial STI, are you offering them expedited partner therapy or patient-delivered partner therapy? Hopefully you know those acronyms, but if you don't, you can Google them. Basically, it's giving medicine to a patient to give to their partner. So again, when we're talking about decreasing the syndemics of STDs and HIV, this expedited partner therapy and patient-delivered partner therapy for partners of the folks you're taking care of could help significantly. And it's legal in Texas. I checked. You know, the legality of it depends state by state. CDC's really pushed this over the last couple of years, but it is legal in Texas. Yeah, and I saw in the DoxyPEP too. I could do an entire lecture on DoxyPEP, but I won't. I agree. Is your jurisdiction prioritizing out-of-care persons living with HIV and diagnosed with a bacterial STI for linkage to care? This is where Ryan White providers and sexual health providers can collaborate with their departments of health who do partner services and partner management on cases. Are they prioritizing? So let's say a young Black man who has sex with men is diagnosed with rectal gonorrhea. That's going to come to attention of the Department of Health, rectal gonorrhea in a young Black male. You know, if they're HIV negative, they need to be linked to PrEP. If they're living with HIV and out of care, they need to be linked to care. I know this is not the way a lot of programs function or think, but when we're talking about data to care and we're talking about the syndemics, we need to start thinking this way. You know, you need to prioritize you need to use STI diagnosis as a way of prioritizing cases that are going to help lead to the end of the HIV epidemic. And then finally, is your jurisdiction monitoring and evaluating the number of bacterial STI cases among persons living with HIV? A lot of places, and I can give an example of Philadelphia because my colleague works there, they need to get a data use agreement anytime they look or combine HIV and STI data because they're separate programs. Oftentimes these are siloed. So for programs that combine the medicine or combine the surveillance information and are able to look in real time at the number of cases of incident bacterial STIs like chlamydia and gonorrhea and syphilis that are being diagnosed among people living with HIV, they're going to be able to focus and help decrease this endemic. Okay, I'm going to shut up.
Oh no, bless it. I'm like, I went to I went to church this morning. Oh my God. Let's give
100.
a round of applause for laying down some data and some information. Brandon, as BPAN, is giving you some little titties. Okay. So here's the deal, fam. We have some juicy data locally as well. So if there is it's 5 till top of the hour. We can shift our rest of our webinar, but if there's 1 to 2 very quick questions, if you want to ask Dr. Furness, we can do that, and then we'll get ready to dive into some of our local data. You can also put some questions in the chat, and then we'll also make sure to follow up there as well, because I know we just digested a ton of wonderful information. Is there 1 or 2 quick questions? Just want to open the floor.
I have a question. That was a phenomenal presentation. Thank you so much. This is such an important issue. Something that I have seen come up again and again is people who have a lot of risks for extragenital sexually transmitted infections and have gone to primary care providers and are not getting the testing they need. They're, just getting a urine test for gonorrhea and chlamydia, no swabs done. How can we improve the education that's getting out to the community, to all of those providers who may not, primarily work with this population, but who have an opportunity and maybe, missing these cases of people who are coming to the person closest to them or who they're most comfortable with?
It's a good question, and I'm going to use an experience that Michael and I both shared because we both work at Whitman Walker Health. But when extragenital screening first started to become the standard of care, we provided it in the 2 publicly funded clinics in Washington, D.C., the Gay Men's Health and Wellness Clinic at Whitman Walker Health, which is where Michael and I know each other from, and then the publicly funded D.C. Health and Wellness Center. And what was happening was that they were talking, there was communication. So this was basically getting at it at the population level. So gay men were talking to other gay men and saying, hey, did you get your throat screened? Did you get your butt screened? If not, go to one of these 2 clinics. And then they were going back to their primary providers and demanding it of their primary providers. We would get nasty calls from some of the providers that predominantly see gay men because they didn't know about this. They had never heard about it. They didn't know if their lab was going to do it, but it was a steep learning curve. So that's one of the indirect ways we did it, is by educating gay men that if they weren't being screened in the throat and the rectum based on their exposures, they weren't being screened appropriately. I will say that we're seeing the same thing happen with DoxyPep right now. So DC is very aggressive with DoxyPep. We go to Pride festivals and prescribe DoxyPep. We went to Mid-Atlantic Leather, which is it's a leather fetish festival, Martin Luther King weekend in Washington, D.C. We prescribed over 400 doses of DoxyPep within the context of Mid-Atlantic Leather. What those individuals do is they learn about it. They can take it if they want, if they have condomless sex during Mid-Atlantic Leather. But more importantly, they go back to their primary providers and they have discussions about it. So they basically say, hey, I learned about, or I took DoxyPep, I'm interested in continuing this, will you prescribe it for me? So that's one of the ways that we try to expand this into what sometimes is the obstinate private provider groups. There are also, we have our surveillance unit also identifies providers who aren't screening appropriately or aren't treating appropriately. And then we have some of the Department of Health or the DC Health and Wellness providers reach out to them for education. We've done that en masse before. When we first started expanding extragenital screening, we got a group of the providers that saw a lot of the gay, bisexual, and other MSM together for a happy hour, and we really talked about it at that point. So hopefully that answers your question. It's not flat, black and dry. Sometimes these providers are very slow at adopting new things. But we get there eventually, hopefully.
Great, thank you.
Great question, Emily. It's great to have you here. Dishes in the house. Let's continue on. We have some local data now. Miranda, do you want to introduce? And we'll continue moving. And we'll also follow up to everything in the chat, if not today, after today. But Miranda, introduce us.
Yes, so I'm sorry, Jamie, I'm introducing Anthony or
Yeah,
linkage.
that's it.
Okay. Okay, fabulous. Well, as many of you have had the awesome opportunity to meet, we do have that EHE epidemiologist, Anthony Benici, and he is very busy. And so it is my pleasure to introduce him. He's going to share some of the local data and also some of the work. We do have a care navigation team here at the county. They do a lot of referrals to the local clinics. Danielle, Marlon, and Marco and Belen are part of our team. And so he's going to share some of our internal data as well. Thank you.
Yes, good morning, everyone. So I'm going to mainly be talking about linkage to care today. That is getting people who are newly diagnosed linked to HIV care and in treatment as quickly as possible. So this first slide focuses on data for Dallas County, the whole county, just the county as a region. And that's for 2022, which is the most recent data that we have available for the county. As you can see on the left, this is showing the percentage of people linked to care in the calendar year of 2022. So of the 896 people who were newly diagnosed in Dallas County in 2022, 655 or 73% of those individuals were linked to care within 30 days. This has slowly been increasing over time. Still good ways to go to get to the 90% goal, but we are moving in the right direction. And overall, the subsequent bars are showing the linkage to care throughout the rest of the calendar year, and ultimately 10% of people who were newly diagnosed were not linked to care at all within that first calendar year. Next slide, please. So this is breaking down all the people who were linked to care within 1 month. So within that 1 month, 424 people were actually linked to care within 7 days. That's kind of under that bracket on the majority of the plot. Of the people that weren't linked to care within 7 days, 231 of them were linked to care sometime within that first month. And ultimately, these 424 individuals represent 47% of all new diagnoses. So 47% of new diagnoses were linked to care within 7 days. Next slide. This is a picture of the EHE team. We don't have Marco on here yet. He just joined a couple weeks ago. And Belen is not here in this picture either. She might have been assisting a patient at the time. But yeah, we have a great team of peer navigators who work very closely with our sexual health clinic and the DIS investigators to help make sure people are being linked to care. So this slide, we're going to now focus down from Dallas County to specifically the sexual health clinic at the Dallas County Health and Human Services office. So they're on the first floor, led by Dr. Nguyen, who I think is on this call. And we've been working closely with the sexual health clinic since about August of 2023 to really have a thorough process from when an individual is newly diagnosed with HIV, and then getting them linked to one of our EHE peer navigators that we showed on the last slide, and then getting them linked to care with one of the clinics that we work with. So this plot is showing how long it takes to get someone from that initial diagnosis linked to care through our sexual health clinic. And so across the x-axis is the number of days from that initial diagnosis to when they are linked to care in an appointment. And you can see the majority of people are getting, it's kind of clustered on the left side of the graph, which is good. And there's a few outliers at the higher end of the scale, you know, over 100 days that took to get them linked to care. And this is showing 33 individuals from August 2023 through February 24 that were newly diagnosed and linked to care through our sexual health clinic. Next slide, please. So ultimately, of these 33 individuals who were newly diagnosed, 67% were linked to care within 7 days of diagnosis, and 91% were linked to care within 30 days. The median number of days to linkage was 9, and an average of 23 days. there's that variation because of the few outliers that took over 100 days to get linked to care. And those few outliers are just due to the challenging nature of maintaining contact with individuals. Sometimes we aren't able to meet the individuals before getting them linked to care, and that can make it more difficult to follow up and really get in contact and get them linked to care. Next slide, please. Okay, so now this plot is just going to compare the linkage rates of the sexual health clinic and EHE peer navigators to Dallas County overall. So in purple is the sexual health clinic, and in blue is Dallas County. So we can see that the sexual health clinic was able to link 67% of new diagnoses to care within 7 days or less. This is 20% higher than the county level of 47%. And for the following breakdown, slightly higher proportions for Dallas County, which are showing that it takes a little bit longer overall to get them linked to care outside of the sexual health clinic. And as of the data that I showed through February 24, there haven't been any individuals that we weren't able to link to care that were newly diagnosed. Next slide. And this is just a quick snapshot of STIs, kind of pivoting a little bit, since that was a big topic of discussion earlier today. In 2022, there were 22,073 cases of chlamydia within Dallas County. And this represents a 22% increase from 2018. There were 10,696 cases of gonorrhea, which was a 46% increase from 2018. And 4,223 cases of syphilis, which is a 62% increase from 2018. So unfortunately, pretty sizable increases across the board for those three STIs. And some of the demographic groups most affected in Dallas County, as alluded to in the previous presentation, young individuals ages 15 to 24 and non-Hispanic Black individuals have the highest rates of STIs in Dallas County. And I think that concludes my presentation. So if there are any quick questions, feel free.
Yeah, thanks, Anthony. Folks, feel free to drop any kind of questions in the chat. One thing that I think is interesting when Anthony was showing internally at Dallas County, right, there are referrals when someone tests positive at the sexual health clinic, they are doing a warm handoff in-person referral to your CHW EHE staff, which includes Belen, Marco, Danielle, and others. So some might be saying, well, how come you were showing me data from August 23 to February 24? Well, that's because your colleagues at the county implemented that new referral process between sexual health clinic and EHE. So since that data has been available, this is the information that we're tracking. And it's fabulous to have this available and these dashboards available. So I want to give a shout out to Anthony and the EHE team, the CHWs, also our colleagues, Dr. Nguyen, Dr. Wada, and others with the Dallas County Sexual Health Clinic. And let's keep this data train moving, folks, and let's get into some of our Ryan White data. Dee, take it away.
Hey, good morning. Good morning. So I will be going over the Ryan Wright 2023 linkage to care QIP data. So the data collected was from our 9 subrecipient agencies. 6 of those agencies provide HIV and STI testing, outpatient ambulatory health services, or OAHS, as I might mention. 3 agencies provide support services. All of these sites connect to our larger linkage to care efforts. Data collected in these following slides will take place between the dates of March 1st, 2023 and February 29, 2024. All sites submitted a QIP metric on a quarterly basis. And one thing that we did this year was look at 3 additional subpopulations of focus for each agency. Next slide. So when looking at outpatient ambulatory sites, what are we looking at, right? So at the denominator looks at new HIV diagnosis who also had a bacterial STI, that's syphilis, chlamydia, or gonorrhea, within plus or minus 30 days of their new HIV diagnosis. Now, when we look at the numerator, it's of those in the denominator who were linked to care within 7 days. You can go to the next slide. So this right here is just an outpatient dashboard. It goes over, so at the top left, we have, this includes our 6 outpatient agencies, and then we go into a run chart. And then to the right, we have each one of these lines represents the quarterly submission, both numerator and denominator. And then we have to the bottom left, our total patient count that was diagnosed with a new HIV and an STI co-occurring, 691. And then we have a bar graph just depicting our linkage efforts. And then to the right, we have what we actually wanted to link and then what we linked. So we were aiming for 90% and we were able to get 77% of linkage to care. So when looking at this run chart of outpatients per quarter, so as you can see, it's kind of up and down. The data has a little bit of variance, but we're properly identifying what should be included in that numerator and denominator, right? And you can see in the trend line, cases of new HIV diagnosis with the co-occurring STI followed up and down with the linkage. So overall, we want to bring these lines as close together as possible. So every time we're getting a new diagnosis, we're also looking at linking them in 7 days. You can go to the next slide. Here we have the bar graph that I showed in the previous. So for the first quarter, we had 187 dual diagnoses, the second quarter 126, third quarter 266, and then the fourth quarter 112. Of those, we have the numbers linked there. In the bar chart, you can see the outpatient sites numerators. So important to note here that for all the quarters actually, the range was between 69 to 80%. I think that was great. This year, we were really establishing a baseline. So we were able to link 77% in 7 days. That doesn't account for the 30 days. So we were doing a great job. If you could see our previous efforts from what Anthony mentioned in 2022, I think we're getting up there, right? You can go to the next.
Yeah,
Oh,
and
okay.
Dee, a big takeaway for me on this slide is that denominator. So again, for our EHE family and Dishes colleagues and community members, so our Ryan White, the folks that do HIV testing and STI testing, over 12 months, 691 people were newly diagnosed with HIV, and they had also had either syphilis, chlamydia, or gonorrhea within 30 days of that HIV diagnosis. So again, it's thinking about what's the proportion of new HIV positives that also have a co-occurring STI, a plus or minus 30-day co-occurring STI. I think that connects back to a lot to what Dr. Furness said, and also supporting that idea that STI testing can be HIV prevention. And so I also just want to give a shout out to all the sites and to Dee for working through this data collection, because it was definitely a journey.
So here we have our support service sites. What were they looking at during our 4 quarters? So the denominator, though, were the clients new to their agency Ryan White services in the quarter being reported, and the numerator focused on of the denominator who were confirmed to be engaged in HIV medical care within the last 6 months. Go to the next slide. It's very important to note that non-clinical agencies have skin in the game too. Everyone has something to offer. So again, we just have our dashboard here outlining what the agencies did per quarter. So this included 3 participating agencies. We were able to confirm 149 clients in care. To the top right, you can see that we have what was submitted for each quarter. And then the bottom right, we have the percentage confirmed in care. The target was 90%, and we were able to confirm 97%. So looking great. So here we have another run chart just explaining what agencies did per quarter. So we were wanting this line to be as closely together as possible, as I mentioned before. So this is really looking amazing. For most of the you can go to the next slide, Jamie. For most of the support services submissions, you can see here that they were only like one or two outstanding areas where they were like, okay, these clients weren't able to be confirmed in care. So that's big. I think we did great here in this area. Looking at the chart, first quarter, we had 100%, second quarter, 98, 95, 92. As the quarters went on, we did not have too much re-engagement in the care for new services with our clients, but as you can see, they still remain in care in those last 6 months. And then the blue just highlighted 97% again. Amazing.
Thanks, Dee.
Thank you, Dee. Sorry, I would like to mention two details. First of all, Dee is the youngest of our team, the Clinical Quality Management Program at Dallas County. He's the youngest, and his enthusiasm actually put him back to school. This guy is a PhD material. So thank you very much, Dee. And thank you to every single agency that we work with. Please don't get tired of us asking you for details. This is the feedback that we're going to give back to you as we promised since the beginning, and appreciate the little agency to the biggest agency. Nobody is bigger than other. Everybody, like Dee said, everybody has a key on this game. So thank you to every single one of you. Thank you, Dee.
Thanks, Dee. Thanks, Oscar. Let me hand it over to my next colleague. Now that we've had a lot of data and we can always provide follow-up, I'm realizing now that I should leave way more information, way more time for discussion. But let's go into the expectations. And I think this is maybe Kevin.
No, that's me.
Sorry, Octavio, go for it, friend.
No, that's okay. So here you can see the cadence of the date when the QIP are supposed to be submitted, and again, the offices will remind folks on when they're expected. But in essence, the first one, it's on the April 24th. Then there is an action period between that and the next one, which will be on June 24th. Then there's another action period before the next one, which is on August 24th, and so on and so forth. And all of these QIP submissions will lead up to the poster symposium, which will take place in December. Next slide, please.
Yeah, thanks, Octavio. So today is that April kickoff. Folks should have all received the calendar holds. So we'll have it in June, August, and October. That August one will probably be in person, so stay tuned. That's why we don't have the calendar series out yet. I'll go to the next slide for you.
Thank you. And sticking with dates, on the 15th of June, and going back to the PDSA forms, which we'll review shortly. On June 15, and again, part of that PDSA forms, it helps identify the root cause analysis. That's part of that PDSA and the PDSA worksheet. Then do also on December the 15th, it's a PDSA form and also an action plan. And then the last date of the 15th of December, again, the PDSA worksheet is expected along with the action plan. And this applies for both Ryan White and EEG subrecipients. And this is now Kevin.
Hi friends, how's everybody? Thank y'all for having me. I'm gonna stay off camera today. I'm a little under the weather, but I'm super grateful to be here. As OP was talking about these wonderful documents we're gonna get into here in a second, but let me go ahead and check and see. Yes, So I'll go ahead and start by sharing some of the AA level activities we've been doing this year and what we'll be continuing to do over the next fiscal year. And that includes reporting to dishes in support of the Part B statewide linkage QIP, share backs of PDSA worksheets, use of the quarterly submissions to provide individualized technical assistance, and generate the background for the capacity building series over the year. Also, the creation and delivery of QIP capacity building series, which we're doing right this very moment, and provision of individualized TA related to the QIP. And of course, we're going to continue our collaboration efforts across the sexual health clinic, ending the HIV epidemic, Ryan White, and DIS.
Thanks,
We can go ahead.
Kevin.
Thank you. I think we can go on to the next slide. Yes. And this is Michael.
All righty, I have really limited time just to kind of do a once over for our process. So we do discovery, a root cause analysis, and an implementation. Based on Piper's comment that just came through in the chat room, you know, these are the questions that we have asked ourselves, and we have doubled down as the region said, yes, we still want to continue this focus because the data that we've collected that was just presented by everyone is that this is literally a public health emergency for the Dallas area. And our values that we're collecting are actually higher or greater than what Dr. Furness was reporting nationally as a problem. Baby, we got to be on this. So we use the model for improvement. You know, there are other recordings and webinars if you need a refresher on it, but the idea is that we set aims as a part of our discovery. So if any of you feel you've accomplished your organizational aim for participating in this project, go ahead and do a new discovery. Feel free to call us in the CQM team and we'll be able to assist you with that. You can set your own measures and step measures to assess the progress of your project locally, but you will still be required to present and report the data that we require on the EMA or regional stage. And we'll also still expect you to be submitting your change ideas that take your root causes into account. If you do a new discovery, we do want you to do a new root cause analysis. And again, we're there to support you on that. New root cause analysis means new change ideas. So we're really trying to be firmer with our implementation of QI as a region, and just wanted to remind you of the model for improvement. Next slide. All right, so we're looking for what's next. And I think this is still me.
No, this is me.
Oh, it's Kevin. All right, Kevin, go ahead.
Before we start, I want to introduce Kevin. Well, everybody knows Kevin, but he's our most recent acquisition, and he's a great asset for our CQM program. And be ready for his energy, be ready for his creativity, innovation. And here it comes. Kevin.
Thank you, Oscar. Hi, everybody. I am going to turn my video off, though. I look like death. So good to see everybody that I know, everybody that I don't know. It's very nice to meet you, and it's a pleasure being a part of this team. And yeah, I'll go ahead and get started into the practical application of the PDSA. So I did want to shed some light on the importance of PCN 1502 as we work with the Ryan White and EG departments. This protocol lays out clear expectations for continuous quality management methodologies within our quality improvement QI projects. I'm thrilled to share that we have continued to use our preferred methodology for QI, and that's to Play and Do Study Act, the PDSA, everything that Ryan White subrecipients are currently submitting right now. Although we're continuing the Linkage to Care project, this is an opportunity for you to start completely new in this new year, while also continuing the work that you've learned over the past year about what the efforts you've done within your organization. We've opted for the PDSA model due to its track record of success in previous projects and the seamless alignment with the objectives of the Linkage to Care initiative. Okay, so I also just want to go ahead and dive into the framework of the PDSA, which includes, obviously planning, doing, studying, and acting. And the beauty of the PDSA is how it ties to continuous learning, adaptation, and improvement over the lifetime of your agency. So I think we can go ahead and go to the next slide. Thank you, Jamie. So I wanted to dive a little bit more into the 3 strategic questions and the PDSA cycles. So you always want to know, what are we trying to accomplish? How will we know that a change is an improvement? And what change can we make that will result in improvement? And I just want to start off with setting aims. We define the overarching goals and objectives of the project. And then we fleshed out measures based on our discovery learnings, identifying specific metrics and indicators to track progress and outcomes. And then we also will dive into the change ideas, considering root cause analysis and pinpointing potential interventions. So of course, we're going to start testing change ideas through small scale experiments, identifying. I think what I learned in a training this year is, it's okay not to have a lot of, it's not always about how many people you have when testing something. It's about the quality of what you're testing. So always starting off small is not a bad thing. And just going into learning how setting measures and identifying change ideas is super important for the QI model. I know I only have 5 minutes left, and I don't want to miss everything. So I do. Is it okay if we skip over to the next slide? Okay, awesome. And I think this might be AJ from EHE. I know, AJ, you wanted to come off and share more about the first phase for the PDSA for EHE subrecipients, which will also be pretty similar to the Ryan Y subrecipients.
Yeah, lucky for us, we have Jamie and Octavio, as well as Mike, or all of them kind of guiding us through this process. And I think we're somewhat getting a little comfortable at this point. But like Kevin mentioned, as far as the next phase, as far as sites established, the smart goals, smart aim statement. We'll be getting more details, especially as we look forward to the summer and us meeting again. Us planning, sites working through the QIP life cycle to discover root causes. That's specifically unique to each of the organizations, because of course we have some non-traditional organizations that we work with. And so those organizations are still clutch in the end of the HIV epidemic. And so, but there's still room for them and meeting their niche and in regards to the end of the HIV epidemic. We'll be looking at who our RCA stakeholders are, and utilizing the tools. So, and then the RCA form will be submitted June 15th. That's the date that we're looking forward to. This is what it looks like. So coming soon, because those haven't been sent out yet, right, Jamie?
Not yet, but as part of the toolkit for the webinar, we'll have both the PDSA worksheet, which is how you document your QI project, whether you're EAG funded or Ryan White. And then just at the beginning of your project is that form on the right, which is that root cause analysis, aka RCA form. We've got pathways in glass cubes and we've got hyperlinks. So they've not been sent out yet, but we will notify everybody when these slides, as well as the forms and the toolkit material, are in glass cubes. Great question, AJ. I'll kind of help round us out and take us home, family. So today has been a total joy and a real blast having Dr. Furness, as well as Anthony and Dee share data at the national, state and county, and then local level. So just a couple of a quick recap, right? So we have this whole next 12 months to work as a coordinated system of care, focused on the same type of QI project. We're going to be focusing on linkage to care. Now we have some of our superheroes here. We have Danielle and others from the EAG team who are doing that work of linking folks to care. And we know we have a huge network. So one of the things we expect is to hear from you all between now and June 15th, of course. We'll be sharing with the resources some different one-on-one time and office hours to support you. But essentially, the next expectation is to figure out who's on your team for this year's QI project and what do you want to accomplish, right? And to go through just some of that planning. We don't want to rush through. We really want to spend our planning with some intention. This data will also be available for benchmarking, for further discovery, and of course, we want to answer any questions that's come up in the chat. So essentially, we really look forward to kicking this off in April of 2024 and seeing what we can accomplish together. Are there any immediate questions or clarifications that we can address? And then I'm going to launch our quick evaluation poll for everyone to hopefully provide some input. Kevin, go ahead.
Hey, everybody, just as a reminder, every subrecipient in this upcoming submission will start at P. Just hoping everybody's on the same page. I know it can be kind of confusing on the continuation of the project, but this is still, you know, a new project for a new year. So just keeping it aligned with the Linkage to Care initiative. Everyone starts at P, we're starting fresh, and yeah, I can't wait to see what you all submit.
Thanks, Kevin. I'll also say, just to be very clear, what if you are a duly funded Ryan White and EHE agency? I'm looking at you, AHF, HSNT, and PRISM. You all have the option. You can do one QI project that integrates your EHE and Ryan White team, or you could opt to do two, right? It just kind of depends. If you're duly funded, the EHE and CQM team, Ryan White, we want to meet with you just to make sure we're all on the same page, right? But you've got some total autonomy and choices in terms of what you want to focus on. Let me go ahead and launch our 2024 QIP poll. If you could, before you log off, take a moment. There's just 5 quick questions. We want to make sure that the meeting and discussions meet your needs. We want to make sure that we're getting the Goldilocks just right amount of time. And we also want to ensure there's areas of opportunity for participation, as well as the content really satiating and satisfying you. And then finally, we want to make sure it's clear what might the next steps be. So we'll leave that open as folks are completing. Thank you to the 8 and 9. Here we go, folks who've already polled. Thank you so much for your conversation today. We look forward to this QIP journey and more to come soon.
Thank you, everybody, for your participation. Thank you so much.
Thank you, everyone.
Thank you to our state partners and for Dr. Furness for joining us and for sharing. You know, we couldn't do this without you. So thank you.
All right. Brandon.
Bye.
Bye, Ms. Helen.
Thanks, everybody.
Thank you, Piper. Thank you all.
Thank you, Ms. Helen. Thank you.